load tests performed in the country, with an average of 480,000 HIV viral load tests per month. The National Health Laboratory Service, that's the NHLS, is the only pathology service provider to the South African public health sector, and we have 19 centralized NHLS HIV viral load laboratories currently operational. The NHLS uses a single laboratory information system. We use a program called TrackCare, and all routine laboratory data is then housed in the NHLS data warehouse. Just want to identify two important limitations with our data warehouse. Currently, we do not have a national unique patient identifier, which obviously poses challenges towards creating reports on patient level data. However, we do have probabilistic record linking algorithms, which can come up with a proxy of patients seen. Also important to note that this is a laboratory data warehouse and doesn't house routine clinical data, such as drug regimens that patients are on. And we'll get to this, I think, during the presentation. So in terms of the various tools, reporting modules that are run from the data warehouse, we have various products. We use a software program called MicroStrategy to develop all of our dashboards and reports. And MicroStrategy has various products, and they have obviously different, let's say, functionalities. So there are dashboards, there are dossiers, there are reporting modules. With regards to our dashboards, we currently use those for program monitoring. They're available at national, provincial, district, facility level. They do facilitate merger of data other than laboratory data, for which we can provide a comparison of the various data sources, and also provide trend analysis. The dossiers allow for more disaggregated analysis and data extraction, which can then be
analyser votre stratégie. Donc, ça dépend de la région, période, l'âge, le sexe aussi. Certaines fonctionnalités, nous utilisons les rapports agrégés, qui est le portage automatisé à différentes parties prenantes. Nous fournissons aussi les laboratoires individuels, les résultats.
Which are designed to identify patients in need of immediate follow-up and care, and thereby improving patient care. And we are currently piloting a results for action dashboard, which will facilitate two-way flow of clinical and laboratory data for enhanced monitoring of the ART program. And I'll be going through these various products that we currently run off the data warehouse. Just to mention that other than the routine laboratory data, there are, of course, other data sources that monitor the HIV program in South Africa. We do have mathematical models. We use those in the data warehouse primarily to estimate the number of people living with HIV. There is also district health information system data, which provides aggregated data. We have a patient level data capturing program at facility level, which is referred to as tier.net, and that essentially is the clinical data repository for the country. It houses both antiretroviral therapy as well as TB treatment patient data. And then we also have a central chronic medicines dispensing and distribution program, which essentially provides less intense models of care. In terms of our current, let's say, gaps in our M&E for HIV viral load, as I've mentioned, we are a custodian of laboratory data, and that is very distinct from various clinical parameters. So within the NHLS data warehouse, we don't have data regarding adherence counseling interventions. So that's highlighted in the red block, the first red block. And then we also, as I've already mentioned, don't have data with regards to regimens highlighted in the below red block there. We can improve in terms of our reporting using the probabilistic record linking algorithm, and we haven't had a look at this yet, but we can get the proportion of non-suppressed patients who have a follow-up viral load and what those results are within the warehouse. So just to put things into perspective, obviously the monitoring of the HIV program is just one of various programs that the National Institute of Communicable Disease is interested in. We have various units ranging from TB to respiratory diseases and vaccine preventable diseases. And all of these various units do use routine laboratory data. But I'll delve into what we do at the Center for HIV and STIs with regards to HIV viral load monitoring. This is what our portal looks like. This is on the MicroStrategy portal that we've developed, and I'm just using our interface as a means of introducing the various reporting modules. So this is the HIV M&E dashboard that I'm going to have a brief look at with you, and you can see that there are various modules within the dashboard. If you look at the top, you can see that we can break this down by pediatrics, all ages. We then have a geographic distribution, which is number one, an integrated district health information system and NHLS data view, and then we have trends. And if you look at the below those three graphics, we have the opportunity to download data, whether that's in PDF or in Excel. And importantly, we also have metric definitions underneath. And certainly there's a lot of detail with the development of dashboards, and it's really important to provide definitions to the users. So just quickly on the geographic distribution, you can see that at the top of the screen, you can evaluate this by year, by quarter, by month, and various age ranges. If you click on national, you're provided with the 9 provinces in South Africa. If you click on provincial view, you'll be provided with the districts as well. This is a view of CD4s on the left-hand side and HIV viral loads on the right-hand side. And you can see a comparison between the current year, which is in lime green, and then the previous year or last year identified by LY, which is in the dark green. And you can manipulate this to choose if you want to see, the number and the proportion of patients with a CD4 count of less than 200. So this was selected for 2020. This is in quarter 4 for the full quarter. And then if you go on the left-hand side of the screen at the bottom, you'll see the total CD4 counts done. This is test level. This is not patient level. And you can see that on that bottom row on the left-hand side table, that 20% of viral loads done in quarter 4 2020 were actually below 200. Similarly, on the right-hand side, you've got the viral load breakdown. In terms of the integrated DHIS versus NHLS view, so this is used, or can be used to see the difference between DHIS data and NHLS data. With regards to laboratory data, obviously we believe that the laboratory has more accurate data. The DHIS data is collected at facility level by healthcare workers, but we can obviously identify gaps where the DHIS is lacking and have improvement within the data capturing of these. And then you've got various indicators on the right-hand side, and you can see that the NHLS data is very comparable to the DHIS data, and you can see this at national level, provincial level. You can also view it at quarterly level. So essentially, this was data for patients more than or equal to 15 years of age, and we have, according to DHIS, 4.86 million, and according to NHLS, 4.83. Trends to facility level. So this is just an example of what the graphic looks like for City of Joburg. You can go on and select a particular facility instead of a district, and you'll get some summaries with regards to that various subcategory or region that you've selected. The trends are not extensive, so this is basically over the past 12 months that are reported upon. And then in terms of the downloads, this is what they look like. So they're fairly rudimentary downloads in Excel. It obviously uses the various categories or breakdowns that are selected on the dashboard. And why I'm showing you this is just to highlight that the dashboard product that MicroStrategy runs is not very user-friendly when it comes to wanting to export historic data and reanalyze and look at trends going back. So on that note, we've actually developed a different tool to monitor the program, which is referred to as dossiers, and I'll go into that just now. But just before that, I want to go into another dashboard, which is our UN 1990 dashboard. So I'm sure you're all aware of the goals which were set for achievement at 2020, which was that 90% of people living with HIV should know their diagnostic status, and 90% of those who know their status should be on treatment, and 90% of those should be virologically suppressed. So we had created this dashboard that was viewable at national, provincial, and at district levels, and we also created it so that we could compare routine laboratory data via the NHLS with DHIS data. So this is a snapshot for February 2021. What you can see is there are 4 columns. The first column on the left-hand side, which has 7.8 million, that is data from the Tembisa model. So that's the mathematical model which estimates the prevalence of HIV in South Africa. So this is data that is then imported into our data warehouse. The second column, which is a proxy for people who know their status, we've set at 90%. And then the third and the fourth columns, which are in the lime green, are the laboratory data, essentially, which is the number of patients with an HIV viral load. This is test level data deduplicated by our algorithm to represent patient level data. And we estimate that 4.9 million people in the past 12 months, so that was from March 2020 to the end of February 2021, which is what this is set at, 4.9 million patients had an HIV viral load test, which can be used as a proxy for patients on ART. And the fourth column represents those patients who are suppressed. And you will note that we have different suppression levels that can be chosen. We have less than 1,000 because that's what the UNAIDS 1990 targets were set at. We have less than 400 so that we can compare with our DHIS, because less than 400 is how the District Health Information System defines suppression. And then we also have selected less than 50 because that is actually according to current South African clinical guidelines. Low-level viremia is now understood to be clinically relevant, and suppression is defined as less than 50. You can then select various age groups, and you can also select sex, which is you can select male or female, and also unknown. And then at the bottom is a small table comparing the current 12-month period with the previous 12-month period chosen. You can see that there has been an improvement in terms of the number of patients who have had a viral load and an improvement in suppression. As already mentioned, it's very important to provide explanatory notes on the dashboards and dossiers, as well as definitions. And I've just put this slide in just to reiterate that although the 1990 cascades are quite simple, that there is still quite a lot of detail, and it's always helpful to have these notes to define the various indicators. So as I've mentioned, the dashboards we found were not ideal for data extraction, manipulation, and reporting. And so we've moved slightly, although we're still maintaining the original dashboards that were designed. We've also developed HIV dossiers in the MicroStrategy portal. And this is a snapshot for the viral loads from the end of February 2021, representing the rolling 12-month period. So essentially, this is March 2020 to the end of February 2021. And you can see that there were 4.9 million patients who had an HIV viral load during this period of time. On the left-hand side in the small table, you've got the various breakdowns per viral load in that particular month. So this is February 2021. And then the second column with the data is representing the rolling 12-month period. So 521,000 viral loads were done at a patient level within February alone, but over the 12-month period, 4.9 million. And then you can see your various virological suppression levels. We've also got a gender breakdown. We do want to monitor unknowns because obviously we want to improve on data capture and quality. Same for age breakdowns. You can see where the bulk of our patients are having viral load testing reside. This slide represents the actual attributes and metrics which have been selected and chosen for the dossiers. So essentially, the dossiers provide an easy way of slicing and dicing the data so that you can disaggregate at region or age or sex or time period. And how it works is you select your metrics, which essentially then disaggregate the data for you, and you select the attributes that disaggregate the data, and then the metrics are what you're actually measuring, like number of tests performed. So this is data that was extracted from the dossiers. The dossiers are very helpful in this way, so you don't have to do manual extracts in the data warehouse. You can immediately extract the data off the dossiers themselves and manipulate the data in an alternate program if it's a bit cumbersome to design in MicroStrategy itself. So this was data that was simply exported in Excel, and what you can see is the various pediatric age groups. And that's broken down then by HIV viral load result. And I mean, the green bars at the bottom of the stat columns represent patients with a viral load of less than 50, what we would in South Africa define as suppression. And you can see that the pediatric and adolescent HIV treatment program is performing extremely poorly in terms of the proportion of patients who are suppressed. We also have a very high proportion of patients who have low-level viremia between 50 and 1,000 copies per mil, and that's represented in amber. And what's also important to take cognizance of in terms of monitoring this is that although the suppression rates are very poor, they do represent a fraction of the overall treatment program. Obviously, our mother-to-child transmission program is fairly robust, and although the absolute numbers are high, in compared to the overall treatment program, they're a fraction of the total patients we have living with HIV. This is just another sort of export and quick analysis, just looking at the difference in viral load suppression between males and females, and it's what the dossiers were designed to do in terms of disaggregating the data and allow for ready analysis. And it's just interesting to see that there are, big differences between male and female suppression, and this is not just in the adult and late adolescent groups, it's also in the pediatric groups, which is interesting in and of itself and does require further analysis. The highest difference is in actually the less than 1 year of age, and that's likely to be associated with an increased risk of transmission in utero if you're female, interestingly enough, and that is supported by other analysis. This is a quick trend analysis that was done off the dossiers, and it allows for a distinction in the trends within various age groups. So the purple line represents all ages, the proportion with the viral load that was less than 1,000, and the red line is the pediatric and adolescent group. And you can automatically see over the years, though, that there has been some improvement in suppression rates in the overall program by 8% over the past, from 2014 to mid 2020. So our dossiers harbor 72 months worth of data. But you can see there's a huge distinction between our pediatric program and the overall program, and it's nice to be able to monitor this in a fashion because it hasn't actually been reported until last year. And then within the pediatric and adolescent group, also quick little trend analysis, you can see that the 1 to 4 age group certainly is an outlier in terms of suppression rates, whereby they do the worst out of all age groups in the AR program, and obviously warrant further support. In terms of our reporting, So these are run off our dossiers, and this is aggregated data that was designed with the National Department of Health Pediatric and Adolescent Technical Working Group. These are the specs that they chose, and essentially this is automated via email reporting. And what you can see, I've just highlighted the national breakdown for February 2021, the various pediatric and adolescent age breakdowns, as well as the greater than 15 years breakdown. And what you have is a monthly view of testing performed in that particular month, number of tests performed, the number of tests less than 1,000 copies per mil, and then the proportion that were less than 1,000, and then also the number less than 50 copies per mil and the proportion there. And you've got various indicators, and you can see the overall program, I mean, with the children is not doing great. We've put a comparison with last year's data for that particular month in gray, so you can compare. There's also, just for sake of space, I left it out on the slide, but you can also view the rolling 12-month data. So you can view data for that particular month as well as rolling 12-month data. And on these reports, there's also graphics that have been designed in Excel that go out with them. In terms of disaggregating data to represent women of childbearing potential and more importantly, pregnant and breastfeeding women, you can, as I've already indicated, select various age groups and sex. And this is representing data for females between the ages of 15 and 45 years of age from February 2021, and you can see that we've got 2.3 million women of childbearing potential have had a viral load in the past year. The little graphic on the left-hand side has the columns to represent each province in terms of the numbers of patients seen within those provinces. You can see KwaZulu-Natal province has the highest number of women who are HIV infected and having a viral load. And then the blue line represents the suppression rate at 1,000 copies per mil. And you can see that although KwaZulu-Natal has the highest number of women essentially living with HIV, they also have proportionately the highest suppression rates. And what you can see on the bottom right-hand side, the little table, essentially if suppression is defined as less than 50 copies per mil, around 75% of women of childbearing potential are suppressed. If you then disaggregate this by the various viral load levels of less than 50, 50 to 1,000, and more than 1,000, you can see, importantly, that once again, if you look at KwaZulu-Natal, which is the highest bar, although they have the highest suppression rate, they still have the highest level of, or the highest number of patients who are viremic. So they've got the highest suppression level, but they've also got the highest number of patients who are not suppressed. In terms of improving on our reporting, so I mentioned we don't have clinical data housed in our data warehouse, and it's obviously an important parameter to identify pregnant and breastfeeding women. So the guidelines were revised, the HIV clinical guidelines were revised in South Africa in 2019. And we tried to leverage a routine laboratory program to assist with identifying pregnant and breastfeeding women. So as a cost-saving mechanism, we have a program in our laboratory information system referred to as electronic gatekeeping. And the idea is it's a cost-saving mechanism that allows the laboratory to automatically reject samples that don't meet certain criteria. So if you have a viral load test, for instance, in the past month, and you have a repeat viral load within that month, that second viral load will automatically be rejected because it's not clinically indicated according to the guidelines. But with the 2019 clinical guidelines, one of the most important changes was that we want every single HIV infected woman at time of delivery to have a viral load. And that would mean that some patients may have had another viral load in the past month or 2 months, and therefore the electronic gatekeeping would automatically reject their test. So to bypass this, National Department of Health decided that we would use specific electronic gatekeeping codes, which would then bypass the rejection but also act as a marker of maternity. So they came up with two codes, and I've just highlighted it in the red circle on the right-hand side of the slide, whereby if a patient is having a viral load antenatally, you put a code which is C#PMTCT. And if they have a viral load at time of delivery, you would use a code C#delivery. And if they had a postnatal viral load during breastfeeding, you would also use the CPMTCT code. But if it was linked to a prior delivery code, then you would know that the patient was actually breastfeeding. So that was the idea. It was kicked off at the end of 2019. And unfortunately, the implementation has been, let's say, very disappointing. It's been very poor. This is a summary of data from February 2021. And you can see that of the total for the country, there was only 6,349 HIV viral loads that were associated with a PMTCT or maternal code. So we expect over 20,000 HIV infected women to deliver live births per month. And obviously this is including not only delivery, but now antenatal as well as postnatal. There is a concerted effort now to try and improve this. But just out of interest, the suppression rates that we're seeing, although the volumes are low, are probably representative of what I've had a good look. A colleague, Faith Moyer, has been doing some analysis looking at viral loads during antenatal delivery and postnatal periods, and the numbers do correlate with what we're seeing here. And just importantly to note, from a programmed point of view, that actually the suppression level during maternity and breastfeeding is lower than the average for women of childbearing potential, which is around 75%, and here it's around 70%. So I want to move to patient level reporting. This is a snapshot of the results for action report. So these are Excel sheets that are consolidated results of patients that require action. We have different products. We have a viral load product, which is represented here. And essentially each row represents a particular patient's episode number. And these can be run daily, they can be run weekly, they can be run for a particular facility, they can be run for a particular district. And essentially it's consolidated exception reporting. You can see that the results in red, so I've highlighted the red block on the right-hand side of the screen. Results in red represent viral loads that were greater than 1,000. Results in amber represent viral loads between 50 and 1,000. And then underneath that, you've got the tests that were rejected. And then the second last column on the right-hand side provides whether there was a maternity EGK group captured, like I've already mentioned. And then the last column represents the total number of previous viral loads that were greater than 1,000. So you can see patient on the second row, their viral load was 2 million, over 2 million, and they've had 3 previous viral loads that were greater than 1,000. So they've obviously been failing for quite some time. And these results or results for action reports were created to try and improve identification of patients who urgently need intervention and care. It's obviously very sensitive information. It's consolidated patient identifying information, and to access these reports, you need to access it through a self-service portal on the NICD website. You need to register with your health profession's number, and you need to give us your details, both your work details, your ID number, and your telephone number and address, and then we vet and approve or disapprove based on that. So, as a means going forward, these are Excel spreadsheets. We wanted to create a dynamic situation whereby the results for action could be updated in a live manner, and that we could also create patient lists and also have an opportunity for this two-way flow of information whereby laboratory data is provided to clinical teams, and clinical teams will then provide us with some clinical data, and that, the idea being, will be improving the overall monitoring program as well as patient care. So this was specifically designed and is being piloted amongst the pediatric and adolescent population. So we have a diagnostic results for action tab But what I want to show you is the patient lists which we have created, which obviously provides for a monitoring component of patients within the HIV program. And what essentially this is if a particular facility is selected, patients who have had any HIV tests or any HIV-associated tests, whether that's an HIV ELISA, whether it's a CD4 test or a rapid test in the laboratory, or if it's a viral load, they will come up at a facility level. So we do not, unfortunately, have the rapid diagnostic test data done at a facility level or in the clinics, but all patients should get a baseline CD4 count. And we hope that all patients on the treatment program obviously are being monitored with viral loads. So they should be represented in the laboratory data. And then by deduplicating using the probabilistic linking algorithm, we can represent patients in a particular facility. And if they've moved to another facility, we can gray them out so that you haven't lost them, but they should come up then at the facility at which their last test, HIV-related test, was performed. And essentially, it's much the same as the results for action. It's got the patient level data, but then some additional columns in terms of their outcomes. What is important is that we can create flags and rules in our data warehouse. So for instance, if you've had a single viral load that was unsuppressed, and you can define that variously. If it was 1,000, you can have a certain flag 1, which is what we've been doing for this pilot. If you've had 2 or more consecutive viral loads that are not suppressed, i.e. what would define failure, you can be flagged and have a flag 2. And then if you've got an overdue viral load result, regardless of whether you are suppressed or not, you can also come up with a rule that you can be a flag 3. And you can design these rules according to your guidelines. And what would happen ideally is the clinical team would then click on a particular patient and their feedback box would come up. And essentially, there is a tracing field that we've designed as well as an outcome field. And these are the options that have been selected. This is a drop-down menu. And you can choose, for instance, if you are locating the file still, you just choose that, and that will then inform the patient list column for tracing. If there's been an outcome that has been acted upon, for instance, you had a patient with a high viral load, you provided enhanced adherence counseling, and if you select that, then the flag drops, and then you've got a viral load outcome, essentially, and the rules will reset for that. And the idea is that we can try and keep up to date with patients who are in need of follow-up and who have patients who have been lost to follow-up or are not in care. So just in terms of summary, so the laboratory data warehouse that we use in South Africa, we've got some advantages. We've got a single laboratory service provider, the NHLS in the country. And it's the only pathology service provider in South Africa. It's a public health sector. We use a single laboratory information system. We do have some limitations, specifically no national unique identifier and the lack of clinical data in the laboratory data warehouse. But I was asked to give some pointers in terms of creating this framework. So in addition to the laboratory information system framework, you obviously also need hardware for the data warehouse. So we use Netezza appliances for our data warehouse. And then you obviously do need software products. There's 2 main sort of software products that are needed. There's the extract, transform, and load software products. We use Informatica. And then there's the business intelligence tools, which essentially create the dashboards and the reporting modules. And we use a MicroStrategy program. And then what's really important is that there are costs involved with the development of these products. And what is essential is also that funds are earmarked for maintenance, because the warehouse itself needs constant attention, as well as the actual reporting modules. They need to be monitored constantly, because there will always be, I think, glitches and updates, and you need a team on standby to be able to address these issues. So this is my last slide. Routine laboratory data can be a cost-effective alternative to expensive and time-consuming surveillance studies. It can reduce the burden placed on the health system regarding facility-level capturing of laboratory test data. I showed you slides comparing DHIS versus NHLS. We've done triangulation studies. Essentially, a lot of the reporting on DHIS is actually unnecessary when we've got the laboratory data on standby. So you can streamline your reporting. The data can be used, the laboratory data can be used to enhance patient care. I've showed you what the results for action reports look like, and this is done in near real time. So it's probably a lot quicker than the clinical databases would be able to provide. Lab data can obviously be used to validate other data sources that would be the most accurate source of laboratory data. Limitations of using lab data obviously are the lack of clinical data. It's ideal to have a unique patient identifier from the get-go, and there is obviously costly investment in the laboratory information system and data warehouse for optimized operations, but there's opportunities as well. I mean, there's the opportunity to merge data from different data sets, and teams are looking in South Africa and merging the clinical data set, tier.net, with the laboratory data. There's obviously opportunities for two-way data flow of clinical and laboratory data, like the results for action dashboard that we're piloting. And there is opportunities to improve and include markers or clinical markers in the laboratory information system, like pregnancy and breastfeeding. And just to acknowledge our team at NICD as well as funding, and yeah, important to note that with regards to ongoing, let's say, mid and long-term sustainability, essentially, it would be critical that these dashboards and reporting modules are funded by departments of health themselves. And my contact details are below as well. So thank you for your time. I will stop sharing from here.
Thank you so much, Ahmad, and thank you so much for that very good presentation. It's really nice to see the kind of work that is happening in South Africa, the kind of dashboard that the country has been able to roll out. There are a number of questions that have come through the chat box. I will be highlighting them to you, and then you can either you answer or you can call up anyone within your team to respond to the question. We have about 20 or so minutes for the discussion of the questions that have been raised. I think I'll go straight to one of the first questions that came from Faith, and Faith is asking, she appreciates the presentation, and then she says, are the dashboard able to pull data from different systems to sources, or is it viewed on a single system?
So we incorporate data from different sources. So for instance, with the 1990 cascade, we actually incorporate data from the Tembisa model for the number of patients living with HIV. So obviously, laboratory data wouldn't be able to tell us that. So we use that as a denominator for the 1990 cascade. Similarly, we incorporate data from DHIS to compare the laboratory data with the DHIS data. And then we obviously have the opportunity to monitor the laboratory data itself. So yes, that's the data, the benefit of having a data warehouse, essentially, whereby you can incorporate other data sources and you can use that as a comparison or a denominator for calculations. So,
Thank you. And the second question basically came from Collins, and he's asking you highlight some of the milestones that South Africa has achieved to get here. Another one, what is basically asking is, how did South Africa get here? If a country is getting started today, or if the country does not have a dashboard today, what would be your guideline?
So this, obviously, we've had the benefit of having a laboratory information system that has been standardized across the country and having a single laboratory service provider. So that's obviously a huge benefit to us. We had moved from a different laboratory information system, but it's still possible to incorporate multiple LISs into a data warehouse, but certainly having a single system and a single service provider, I think, does assist with that. And then there was investment from the organization for the actual warehouse, and that is a I mean, I don't have the figure on me, but the Netezza appliance is costly itself. So there was obviously institutional support for this. And the initial institutional support was actually from a business standpoint. I mean, you can see the volumes of tests that we're performing. So initially, my understanding is that it was a business that required to know, how many tests are being performed for billing and logistical reasons and planning reasons. But then, I mean, my institute is obviously responsible for surveillance. And that was a secondary consideration for the warehouse, but certainly something that I think we would like to build upon. I think really the institutional support is key for sustainability. It's quite easy to have an extract and analyze data, but essentially if you want it to be done in near real time and you want quick reporting that can make a difference, especially at patient level, you really do need buy-in from the institutions and departments of health, and then also teams on the ground that can actually act on these results. So, yeah, I mean, another benefit that we have with our laboratory information system is that results are accessible throughout the country via the internet.
So thank you for that. The other question came from Anafi, and as you know, currently there is some kind of a shift whereby every single effort needs to be put in place to make sure that the results are being delivered to the patient. So Anafi is asking, or is wondering, what are the main hindrances toward ensuring results are sent to the patient?
So, yeah, I think there's a different model of care that needs to be considered. The model of the healthcare provider who took the sample and is responsible therefore for retrieving the result and acting upon it is just not feasible with the huge program that we have in South Africa, both for HIV and TB. And that's why we've moved to these results for action reports that we do obviously work with our district support partners to act upon these results. I don't think we have the answer to that. I wish we did, but it is a constant struggle, I think, to ensure that results are reported to the correct people or persons or patients even, and acted upon in a timely manner. Obviously, internet connectivity does support this, and essentially all results are available and accessible at all times across the country, but then you do have issues with regards to internet connectivity at facilities, and there is obviously people who are using their own data and people who refuse to use their own data for these. At an organizational level, obviously the district support partners are supported in this regard, but facilities may struggle, and I don't have a footprint of connectivity at facility level of what's happening, but it's very easy at an individual healthcare provider level to look these results up on your phone or on a tablet or at a computer if it's accessible.
Thank you for that. There's a question that came from Collins, and I would want also to link that up with a question from Miriam. Collins is asking, there are 1.5 patients on less intense model of care. And he is asking, is the viral result considered in choosing the most appropriate model? And I'll link that question up with what Miriam is asking. I believe Miriam is from Uganda. And Miriam is asking, kindly share an update on how you monitor result utilization.
I don't think I quite understand the question, sorry.
So let me rephrase the question. Collins is asking, I think from the presentation he picked that there are about 1.5 million patients on less intense model of care. And the question is asking is VL result considered in choosing an appropriate model? Yes.
So to meet the CCMDD requirements, you need to be virologically suppressed. And also age is also considered. Age is also considered. So I believe that they're expanding the the less intense models of care to children now older than 5 years of age, but it has generally been restricted to older people living with HIV, and you need to meet certain criteria, such as having 2 viral loads that were suppressed over a period of a year or more.
Thank you. And now to Miriam's question, let me ask it independently. She's asking, you kindly share an update on how you monitor result utilization. Is there a mechanism to track whether the results are being utilized?
Yeah, so that's obviously a great question. So in terms of our reporting modules, we can now monitor accessing the results for action reports. So those consolidated reports, we have, like I mentioned, a self-service portal, and on that portal, we can monitor utilization of the results for action. It's not obviously 100%, because what we find is that there are point personnel who access the results for action reports and then will distribute them themselves. And obviously we are unable to monitor that subsequent distribution. We would ideally, for the sake of protection of personal information, ideally want users to register and utilize themselves. But we can't prevent individuals from downloading these reports and distributing them. Obviously, there are terms and conditions of usage, and if that is taking place, they need to be aware and take full responsibility for password protection for that. So that there was a terms and condition page associated with these. So we can monitor that, but yeah, in terms of the individual patient level data, that's not something that I'm involved with in terms of monitoring of track utilization. There are audit trails, so you should be able to see if an individual result is accessed by any user on the National Laboratory Information System. That is actually also accessible. I don't know if anyone has actually been monitoring that.
Okay. There's a question from Faith, and I'll link it up with the question from Miriam. Miriam started by asking, since there are no unique identifiers that you have in the country, she would want to hear a little bit more how you're able to link data from facilities to the main national database. And then related probably to that is a question of just highlighting the data flow from facilities to the laboratories. So I hope that is clear.
Yeah, so in terms of the unique patient identifier, so there is a move towards using actually the South African ID and creating a health patient registration number, and there's a whole health patient registration system that we will be incorporating into the warehouse in the future. But for the moment, what we have are algorithms, and there's many of algorithms that have been created. And what they're mostly based on is the patient demographics. So the name, the surname, the date of birth, the facility number used, the region, and it creates a unique number or identifier based on the patient demographics, which can then be linked. So you can get patient level data or a proxy, especially for surveillance purposes, from the test level data, whereby 2 patients with exactly the same name, the same date of birth are merged. And none of these are 100%. So the estimated sensitivity of our linking algorithm that we're currently using in the warehouse is around 85%. Boston University has created, I think, a much more sensitive algorithm that we're currently incorporating into our warehouse. It's not ideal, as I mentioned, going forward. If effort can be made towards creating a unique patient identifier that is available at birth, that would be ideal. We really struggle with monitoring our PMTCT program because over half of all children born in South Africa have a name registered in the laboratory, which is baby or born to or baby girl or baby of, and a fraction, I think it's less than 1%, have an ID number at the time of birth registered. So to be able to link our birth test to subsequent tests is impossible using any algorithm. And there are alternatives that can be provided. So one of our provinces, the Western Cape, does have unique folder numbers used throughout the province. That's very helpful. The other alternative that was evaluated in a pilot project is providing a unique identifier with the Rota Health booklet, which is available at birth. It doesn't discriminate against nationality, and you can easily barcode these immunization booklets and use them for other public health surveillance. And the pilot worked well. Unfortunately, it wasn't taken on or hasn't been taken on yet by the Department of Health, but hopefully it will still be considered.
Thank you. I
So
think
that was with unique identifiers. Sorry, the second question, Michael, if you just remind me.
the second question was basically asking me to highlight how the data flow from various facilities in the national database.
So we've got one laboratory information system. So essentially samples are taken at the bedside. They come with a laboratory request form, right? The request forms we use are barcoded. So the samples get an immediate barcode that should be unique for that specimen draw at that particular time. They then get registered in a registering laboratory and come out with a unique episode number that is specific to that sample taken at that point in time. Those samples after registration will go through to the testing laboratory. I indicated there's 16 HIV viral load test labs in the country, and the result will then be run, and the result will then interface with the laboratory information system. So once the sample is registered in the registering laboratory, it's on the laboratory information system, the demographics are captured, and then it will go for a test, and that test will then interface either automatically or through a pathologist or technologist manually verifying the result. Once the result has been verified, it is automatically accessible anywhere in the country via the internet. But obviously we do have other processes whereby results are printed and distributed. I can't really comment on the logistics in terms of how it works in different regions of the country. But once a result is verified, essentially it is accessible in two different ways, electronically as well as sort of on a hard copy. The data from TrackCare, once it's verified, will come to essentially a loading zone in our warehouse. And the ETL processes will ensure that once the result lands in the centralized warehouse, it gets distributed into various tables, whether that's the demographic table or the HIV result table or the TB table. And that is an ETL process. And I mentioned that the software that we use for that is Informatica, and those IT specialists are hard to come by. Yeah, that is obviously a limitation within using sort of this large data set. Once it's in our warehouse and is in the various tables, then we have developed sort of business intelligence tools using MicroStrategy. And that's essentially where our portal comes from, and the interface that I use that's sort of on the internet, and I can look at the various dashboards and dossiers, and you can look at these remotely as well. You don't have to be on site. Hopefully that explains the general sort of data flow.
Yes. So, and again, thank you so much for that. And maybe we have about 4 minutes before the top of the hour. So I'll ask the final question. The question touches on access. The trade is asking who has access to the data.
So that's, yeah, obviously really important. So it depends what data. If there is a request for the clinical identifying data, then you have to be a healthcare worker registered. And if not, you have to obviously provide reasons why you want access to patient level data. If it's in terms of the various sort of aggregated data that is reported to the Department of Health at national and provincial and district level, we work obviously closely with the Department of Health, and they inform us who should be being emailed these reports, and that's updated regularly via the technical working groups. Personally, I would obviously like to enhance access to de-identified data, and I think it's always something that I try and raise. But yeah, it is essentially limited to who the Department of Health says can access the data.
Thank you so much. We have about 2 more minutes, so I'll ask the final question. The questions come from Fox, and he is asking, for non-patient level aggregated data, is it possible to export the complete dossier dataset as you showed?
Yeah, so those graphs that I showed in Excel, that was data that was immediately exported from the dossiers. So we have a huge program in South Africa, and I mentioned we don't have capacity on the dossiers to look at 10 years worth of data just because of the numbers. But we have managed with 72 months of data where you can look at trends, and that data is automatically exportable in an Excel format that can then be imported in whatever software, whether it's Stata or R, for further analysis. And it all depends on what attributes and what metrics were decided in developing the dossiers. But the more, let's say, breakdown that you've chosen in terms of your age groups, the more the data would be accessible. So you'll see that on our dossiers, we had a much more nuanced breakdown, specifically to evaluate the pediatric program than was created on the dashboards, which was so yes, that is really, in terms of one of the best things about having these dashboards or dossiers accessible is the direct access to the data for speedy analysis, whereby you don't have to do a time-consuming manual export. It's all pretty much been pre-digested for you.
Thank you so much. We have 1 more minute before the top of the hour, so I won't take more questions, but I'll collect the question I've been asked and send them to you, so that as I'll be sending the update to the team, then the response to the question will be included. I don't know whether, Ahmed, you have any closing remark, either you or plus any other person from South Africa team. Please go ahead, make some closing remarks and any guidelines that guidance will be having to the country team. Please go ahead. Thank you.
Michael, if I may speak, I know it's the end of the, I just want to thank Dr. Hamad for his brilliant presentation on behalf of the South Africa team. This is really great. I think it's a good start for South Africa to be part of this M&E community of practice. Thank you very much. Over.
Thank you, Karindia. Ahmed, any closing remarks?
No, thanks very much for the opportunity.
You're welcome. So we are right at the top of the hour. Just to highlight, the next session will be on 1st of April. And you'll basically be diving in on indicators, and our CDC Atlanta will be making the presentation. So we are looking forward to that presentation. Just to highlight, before the next presentation, there is some assignment that was shared with you, and basically we're supposed to map your data flow. Let me bring that slide up for only a minute. Give me a second. I can't pull the slide as fast as I'd have wanted to, but basically I shared that slide with you, and the request was just mark your data flow, because that would be what we'll be tackling in our next session. I've seen the comment from Miriam, and she is highlighting that they have a similar system within Uganda, and she'll be more than willing to share. And we have a session for South sharing that will be happening on 15th of April. So I'll be reaching out to you, Miriam, and the team to see how to go about that in the next South session. So thank you so very much. At the top of the hour, thank you, team, for participating. Look forward to other exciting sessions that will be coming. I'll be sharing the presentation and the recording. Thank you. Good morning, good afternoon, and good evening, everyone. Bye. Goodbye.